What if I told you that the most terrifying chapter in the history of medicine wasn't written by sadists or monsters, but by compassionate doctors who genuinely believed they were saving lives? What if the greatest horrors of Victorian psychiatry emerged not from malice, but from hope? The story of the Victorian Asylum chair forces us to confront an unsettling truth. Sometimes the most dangerous people are those who are absolutely certain they're doing good. When we imagine Victorian asylums, we picture Gothic dungeons and cruel wardens. But the reality was far more disturbing. These institutions were built by reformers, funded by philanthropists, and operated by educated physicians who saw themselves as pioneers of enlightened medicine. They didn't set out to torture their patients, they set out to cure them. And in that noble pursuit, they created instruments of suffering so sophisticated that they make medieval torture devices look primitive by comparison. Today, we're going to examine one of the most chilling examples of good intentions gone catastrophically wrong: the Victorian rotational therapy chair. This wasn't just a restraint device. It was a machine that spun human beings at devastating speeds, based on the sincere medical belief that centrifugal force could reorganize the chaos of the human mind. It represents the moment when the age of reason collided with the mystery of madness, and reason lost its way entirely. This is not just a story about a chair. It's a story about the arrogance of certainty, the seduction of control, and the thin line between healing and harm. It's a story that should make us question every confident claim about progress, every institutional promise of benevolence, and every time we're told that suffering is necessary for someone's own good. Chapter 1: The Machine of Mercy When Compassion Became Cruelty. Walk through the polished corridors of a prestigious Victorian asylum in 1820, and you would not find the hellscape of popular imagination. Instead, you would discover something far more unsettling: an institution that looked, smelled, and felt like progress itself. The floors gleam with fresh wax, the walls are painted in calming pastels, and sunlight streams through tall windows onto potted plants and carefully arranged furniture. The air carries the scent of lavender water and carbolic acid, the Victorian perfume of scientific cleanliness. At the center of this world stands our first archetype, the physician reformer. He is not a cackling villain, but a man of genuine learning and humanitarian ideals. Dr. Joseph Mason Cox, the inventor of the rotational chair, corresponded with the greatest minds of Europe. He read philosophy, studied anatomy, and genuinely believed he was bringing light to the darkness of mental illness. To him, the human body was an intricate hydraulic system, a network of fluids and pressures that could be adjusted, regulated, and perfected through the application of scientific principles. This is where the tragedy begins, with a metaphor taken fatally literally. If the body is a machine, then it can be fixed with mechanical interventions. If madness results from stagnant or misdirected blood flow in the brain, then centrifugal force could redistribute those fluids and restore mental equilibrium. The logic was seductive in its simplicity, terrifying in its confidence. The rotational therapy chair emerged from this collision of Enlightenment rationality and industrial innovation. Picture a substantial piece of furniture, often crafted from fine mahogany or oak, suspended from the ceiling by a system of gears and pulleys, or mounted on a central pivot. At first glance, it resembled an elegant piece of drawing room furniture, perhaps slightly oversized and unusually rigid, but nothing that would immediately alarm a casual observer. The engineering, however, revealed its true purpose. The chair was designed to rotate a human body at speeds of up to 100 revolutions per minute. The patient would be secured with an elaborate system of leather restraints, thick straps across the chest, waist, thighs, and ankles, with additional bindings for the wrists, and a specialized head brace to prevent neck injury during the violent spinning. Some models included wooden boxes or metal cages that enclosed the patient's head entirely, creating complete sensory deprivation while the body underwent its mechanical ordeal. The medical theory behind rotational therapy rested on several interlocking beliefs that dominated early 19th century psychiatry. First, there was the hydraulic model of mental illness, the idea that madness resulted from improper circulation of blood and other bodily fluids in the brain. Second, there was the concept of therapeutic shock, the belief that a sudden, dramatic intervention could disrupt pathological patterns of thought and behavior. Third, there was the mechanical philosophy that viewed the human body as a complex machine that could be repaired through the application of external forces. Dr. Cox and his colleagues genuinely believed they were offering a breakthrough treatment that would revolutionize the care of the mentally ill. They documented their procedures meticulously, published their results in respected medical journals, and trained other physicians in the proper use of rotational therapy. When they wrote about their work, they used the language of salvation, not torture. They saw themselves as liberating patients from the chaos of madness, not inflicting additional suffering upon them. Yet the physical reality of the chair told a different story. The heavy leather restraints were designed to be inescapable. The head brace, euphemistically called a head fixer, clamped the skull in place with enough force to prevent any movement that might reduce the therapeutic effect of the spinning. The blindfolds used during treatment weren't just to increase disorientation, they were to prevent patients from focusing on stationary objects that might help them maintain some sense of orientation during the ordeal. The chair sat at the intersection of medicine and discipline, therapy and intimidation. While doctors could tell themselves they were administering a precisely calibrated dose of centrifugal force, the chair also served as the ultimate threat in the asylum's system of behavioral control. Patients quickly learned that certain behaviors, shouting, fighting, refusing to follow orders, could lead to time in the spinning chair. The device became both treatment and punishment, cure and coercion. The Victorian era's obsession with moral management, the belief that mental illness could be cured through environmental control and strict discipline, found its perfect expression in the rotational chair. Here was a device that could enforce absolute stillness and submission, while simultaneously delivering what doctors believed to be therapeutic intervention. It represented the ultimate fusion of Victorian values, scientific progress, moral authority, and social control unified in a single, terrifying machine. But the doctor rarely operated the chair himself. That task fell to others, people whose names rarely appear in the medical literature, but whose hands turned the cranks and tightened the straps. To understand the true horror of rotational therapy, we must descend from the realm of medical theory into the world of daily practice. We must meet the attendants who made the nightmare real and witness what happened when enlightened theory collided with human flesh and bone. The machine is waiting, the straps hang open, and the silence of the treatment room is about to be shattered by the grinding of gears and the sound of human suffering transformed into scientific data. Chapter 2. The invisible hands servants of a broken system. If the physician represented the mind of the asylum, the theory, the authority, the comfortable distance from consequence, then the attendants represented its muscle, its sweat, and its intimate knowledge of suffering. These were the invisible architects of the rotational therapy system, the working-class men and women who transformed medical theory into physical reality. They have left almost no trace in the historical record. Yet they were the ones who made the chair spin, who heard the screams, who cleaned up the aftermath. The attendants occupied a precarious position in Victorian society. They were typically drawn from the laboring classes, former factory workers, failed tradesmen, domestic servants seeking steadier employment. They possessed little formal education, but were expected to manage some of the most challenging and dangerous work imaginable. The physical control of people whose behavior had been deemed uncontrollable by society itself. The pay was meager, the hours exhausting, and the psychological toll immense. Turnover was constant, as many attendants lasted only weeks or months before the combination of physical danger and moral distress drove them to seek other employment. For these workers, the rotational chair was not a philosophical experiment or a medical breakthrough. It was a job requirement that demanded both physical strength and emotional detachment. The chair did not spin itself. In the early decades of its use, before steam power was adapted for medical purposes, the mechanism was entirely hand-operated. It required sustained, vigorous cranking to achieve and maintain the prescribed rotational speeds. Picture the scene in the treatment room, typically located in the asylum's basement or a secluded wing to contain the noise. The walls are bare stone, cold and damp to the touch, echoing every sound with stark clarity. The air is heavy with the smell of fierce sweat and the metallic tang of the iron machinery. Gas lamps flicker in wall sconces, casting dancing shadows that seem to writhe in sympathy with the patient's terror. In the center of this chamber stands the chair, its polished wood gleaming ominously in the lamplight, its leather straps hanging like the tentacles of some mechanical predator. The attendant approaches his task with the grim efficiency of repetition. He has done this before, perhaps dozens of times, perhaps hundreds. He knows the routine so well that he can perform it without conscious thought, which is perhaps the only way he can perform it at all. The patient is brought in, often struggling, sometimes screaming, occasionally catatonic with terror. The attendant must force unwilling limbs into the chair, feel the tremors of fear in the patient's body, hear the desperate pleas for mercy that he has learned to ignore. The process of securing a patient in the rotational chair was itself a form of violence. The restraints had to be applied in a specific sequence to prevent the patient from injuring themselves or others during the struggle. Legs first, to prevent kicking. Arms next, to stop flailing and striking. Then the torso strap, pulled tight across the chest to prevent the patient from throwing their weight forward during rotation. Finally, the head brace, the most crucial and most terrifying component, clamped around the skull with mechanical precision. Each strap had to be checked and double-checked. Too loose, and the patient might work free during the spinning, suffering severe injury as centrifugal force threw them against the chair's frame. Too tight, and circulation could be cut off, leading to permanent damage or death. The attendant walked a narrow line between restraint and strangulation, guided by experience rather than precise medical knowledge. Once the patient was secured, the attendant took his position at the hand crank. The mechanism was geared for mechanical advantage, but it still required considerable strength to achieve the prescribed speeds. 40 revolutions per minute. 60. 80. 100. The doctor would call out the target speed, and the attendant would adjust his rhythm accordingly, watching the patient disappear into a blur of motion while he maintained his steady mechanical pace. The attendant witnessed things that the doctor, in his brief visits to observe the treatment, never saw. He saw the immediate physical effects of the spinning, the way the patient's face drained of color, turning a sickly gray-green as blood was forced away from the brain. He heard the change in the quality of their screams as centrifugal force compressed their lungs and distorted their vocal cords. He smelled the sharp, acrid odor of terror sweat and the fouler smells that followed as the patient lost control of their bodily functions. Most disturbing of all, the attendant was responsible for the aftermath. Rotational therapy induced violent, uncontrollable nausea in virtually every patient. This wasn't an unfortunate side effect. It was often the intended result. Victorian medical theory held that purging the stomach was part of the therapeutic process, a physical manifestation of the mental cleansing taking place. So the attendant's duties included not just operating the chair, but cleaning up the vomit, urine, and excrement that resulted from the treatment. The clean, scientific procedure described in medical journals was, in daily practice, a filthy, degrading ordeal for everyone involved. The psychological impact on the attendants themselves was rarely acknowledged, but clearly documented in their behavior and turnover rates. Some developed a callous indifference to patient suffering, viewing their charges as objects to be manipulated rather than human beings in distress. Others experienced what we would now recognize as symptoms of trauma, nightmares, emotional numbness, difficulty maintaining relationships outside of work. A few became advocates for reform, using their insider knowledge to expose the realities of asylum treatment. But these voices were typically marginalized or dismissed as unreliable. The relationship between attendant and patient was complex and morally ambiguous. To the patient, the attendant was the immediate agent of their torment, the person whose face they saw as the straps were tightened and the spinning began. Yet the attendant was also trapped within the system, following orders from medical authorities whose education and social position made their commands seem unquestionable. Many attendants convinced themselves that they were helping the patients, that the temporary suffering of the chair was preferable to a lifetime of madness. Others simply focused on the mechanical aspects of their job, turning the crank with the same emotional detachment they might bring to operating any other piece of machinery. The rotational chair also served as an instrument of institutional control that extended far beyond its direct victims. The threat of the chair shaped behavior throughout the asylum, as patients learned to suppress any actions that might be interpreted as requiring therapeutic intervention. The device became a silent presence in every ward, its potential use hanging over daily interactions between staff and patients like a sword of Damocles. Some attendants developed sophisticated techniques for managing this system of fear. They might threaten patients with the chair to maintain order, using the device's reputation as a tool of behavioral control. Others tried to minimize its use, finding alternative ways to manage difficult situations, though such compassionate initiatives were often discouraged by supervisors who viewed them as signs of weakness or insubordination. As the attendant wiped down the chair after another session, removing the evidence of human suffering from its polished surfaces, he might have wondered about the morality of his work. But such thoughts were dangerous luxuries in a world where employment was scarce and questioning authority could lead to immediate dismissal. So he prepared the chair for the next patient, checked the restraints, and waited for the doctor's next order. The invisible hands that operated the rotational chair were not evil, but they were complicit in a system that transformed medical theory into human agony. They were ordinary people caught in extraordinary circumstances, making choices that seemed reasonable within the context of their time and place, but appear monstrous from our current perspective. Their story reminds us that the greatest horrors in human history are often perpetrated not by monsters, but by people who are simply doing their jobs. Chapter 3. The Ritual of Reason: How Science Sanctified Suffering. We have seen the theory and witnessed the practice. Now we must experience the ritual itself, the precise, methodical ceremony that transformed a human being into a subject of mechanical intervention. The Victorian rotational therapy session was not a chaotic act of violence, but a carefully orchestrated medical procedure, performed with the solemnity of a religious rite and the precision of a scientific experiment. Understanding this ritual reveals how ordinary people can participate in extraordinary cruelty when that cruelty is embedded in professional protocols and institutional authority. The Victorian era was defined by its obsession with order, control, and social propriety. Emotions were to be contained, bodies were to be concealed, and social interactions were governed by elaborate codes of etiquette. Mental illness represented the ultimate violation of these principles. It was the complete breakdown of self-control, the public display of private chaos. The rotational chair was designed not just to treat madness, but to enforce conformity, to physically compel the disordered mind back into socially acceptable patterns of behavior. The procedure began with the preparation ritual, a formal process that gave medical legitimacy to what was essentially an act of violence. The patient would be brought to the treatment room by a team of attendants, their arrival carefully documented in the asylum's medical records. The attending physician would conduct a brief examination, noting the patient's pulse, respiration, and general condition. This preliminary assessment served multiple purposes. It provided a baseline against which to measure the treatment's effects, it demonstrated medical oversight of the procedure, and it gave the doctor an opportunity to make final adjustments to the prescribed treatment intensity. The diagnostic language used to justify rotational therapy reveals the elaborate intellectual framework that Victorian physicians constructed to rationalize their practices. A patient might be described as suffering from cerebral congestion, requiring the centrifugal redistribution of blood to restore proper circulation. Another might be diagnosed with nervous excitement, necessitating the calming effects of controlled mechanical shock. The medical vocabulary transformed human distress into mechanical problems requiring engineering solutions. The physical preparation of the patient followed a strict protocol designed to maximize both safety and therapeutic effect. The patient's clothing would be examined and modified, with any items that might cause injury during rotation, buttons, belts, jewelry, removed or secured. Special garments, essentially straitjackets modified for rotational use, were sometimes employed to prevent the patient's limbs from being damaged by centrifugal force. The patient's hair would be secured or covered to prevent it from becoming entangled in the chair's mechanism. The seating and restraining process was performed with ceremonial precision. The patient was positioned in the chair according to the physician's prescription, upright for treatments targeting blood flow to the extremities, reclined for interventions focused on cerebral circulation. The leather restraints were applied in a specific sequence, each one checked by a second attendant to ensure proper tension and security. The chest strap was positioned to allow breathing while preventing the patient from throwing their weight forward during rotation. The limb restraints were tightened to prevent movement while avoiding the complete cessation of circulation. The head restraint system was the most critical and most terrifying component of the apparatus. The patient's skull was positioned in a padded clamp that could be adjusted to accommodate different head sizes and shapes. This device, euphemistically called the cranial stabilizer in medical literature, served multiple functions. It prevented potentially fatal neck injuries during high-speed rotation. It ensured that the brain received the maximum therapeutic benefit from centrifugal force, and it eliminated the patient's ability to turn away from the experience or seek visual reference points that might reduce the treatment's disorienting effects. The application of blindfolds completed the patient's sensory isolation. Victorian physicians justified this practice by arguing that visual stimuli could interfere with the therapeutic process, allowing patients to maintain some sense of orientation during rotation. In reality, the blindfold served to intensify the psychological impact of the treatment, trapping patients in a world of pure sensation where the only reality was the overwhelming experience of spinning through space. The rotation itself followed precise protocols that varied according to the patient's diagnosis and the physician's theoretical approach. Treatment typically began with slow, gentle rotation to allow the patient's body to adjust to the motion. The speed would then be gradually increased according to a predetermined schedule, with careful attention paid to the patient's physiological responses. The attending physician would monitor pulse rate, breathing pattern, and skin color, making adjustments to the rotational speed based on these clinical observations. The prescribed speeds were startlingly high by modern standards. 40 revolutions per minute was considered a mild therapeutic dose, suitable for elderly patients or those with delicate constitutions. 60 to 80 revolutions per minute represented standard treatment intensity for most conditions. The most severe cases might require speeds approaching 100 revolutions per minute, a rate that produced forces equivalent to those experienced by modern astronauts during rocket launches. The sensory experience of rotational therapy was indescribable in its intensity. Within seconds of reaching therapeutic speed, the patient would lose all sense of spatial orientation. The fluid in their inner ears, responsible for balance and spatial awareness, would be thrown into chaos by the centrifugal force. Even behind the blindfold, the sensation of motion was overwhelming, creating a nightmarish experience of falling through endless space while simultaneously being crushed by invisible forces. The physical effects were immediate and devastating. Blood was forced away from the brain and toward the extremities, causing a profound alteration in consciousness that physicians interpreted as therapeutic breakthrough. The patient's heart would race as it struggled to maintain circulation against the artificial forces acting on the body. Breathing became labored as centrifugal force compressed the lungs and altered the mechanics of respiration. The digestive system would rebel violently, producing the nausea and vomiting that doctors viewed as evidence of successful treatment. The psychological impact was equally severe. Patients experienced a complete loss of control over their physical environment, a terrifying dissolution of the boundary between self and world. Many reported feeling as though they were dying, as though their body was being torn apart by invisible forces. The experience was so overwhelming that it often produced a state of shock that physicians mistook for therapeutic calm. The termination of treatment required its own careful protocol. The chair would be gradually decelerated rather than stopped abruptly, as sudden cessation of rotation could cause severe injury or loss of consciousness. Even after the chair stopped moving, patients remained disoriented for extended periods, as their vestibular systems struggled to readjust to normal conditions. The removal of restraints followed a specific sequence designed to prevent patients from injuring themselves in their confused state. The post-treatment evaluation was crucial to the maintenance of rotational therapy's medical legitimacy. Physicians would carefully document the patient's condition immediately after treatment, noting changes in pulse, respiration, and behavior. The temporary docility that often followed rotational therapy, actually a form of traumatic shock, was interpreted as evidence of therapeutic success. Patients who emerged from the chair quiet and compliant were considered improved, regardless of their actual psychological state. This ritual of scientific torture reveals the seductive power of institutional authority and professional expertise. The elaborate protocols, the careful documentation, the medical vocabulary, all of these elements combined to create a system that could transform obvious cruelty into apparent therapy. The physicians who prescribed rotational therapy weren't sadists, but believers in the power of reason and science to solve human problems. Their tragedy was not malice, but certainty, not cruelty, but confidence in their own righteousness. Chapter 4. The Price of Progress When Healing Becomes Harm. As we reach the end of our journey through the nightmare of Victorian rotational therapy, we must confront the most disturbing question of all. What does this history tell us about ourselves? The physicians who built and operated these machines were not monsters from a distant, primitive age. They were educated, well-intentioned professionals who believed they were advancing the cause of human welfare. They lived in a society that celebrated scientific progress and rational thinking. They were, in many ways, just like us. The immediate aftermath of a rotational therapy session revealed the true cost of this medical breakthrough. Patients emerged from the chair in a state of profound physical and psychological trauma. The temporary calm that physicians interpreted as therapeutic success was actually a form of shock, the mind's protective shutdown in response to overwhelming sensory assault. Many patients remained disoriented for hours or days after treatment, their sense of balance permanently disrupted, their trust in their own perceptions shattered. The long-term consequences were even more severe. Repeated exposure to rotational therapy created what attendants grimly called chair madness, a specific pattern of behavior characterized by catatonic stillness alternating with explosive violence, as though the mind was forever trapped between the enforced immobility of the restraints and the desperate need to escape. Patients developed profound phobias of enclosed spaces, of being touched, of any situation that reminded them of their helplessness in the chair. Many never recovered their psychological equilibrium, spending the remainder of their lives in a state of fearful hypervigilance. The physical damage was equally devastating. Prolonged exposure to high-speed rotation caused inner ear damage that left many patients permanently dizzy and disoriented. The violent nausea induced by the treatment often resulted in severe dehydration and malnutrition. Some patients suffered strokes or heart attacks during treatment, their cardiovascular systems unable to cope with the artificial forces acting on their bodies. Others experienced what we would now recognize as traumatic brain injury from the repeated jarring of their skulls against the restraining apparatus. Yet the physicians who administered these treatments remained convinced of their therapeutic value. Medical journals of the period are filled with case studies describing the remarkable improvements observed in patients following rotational therapy. What these accounts reveal, when read with modern understanding, is a systematic pattern of misinterpretation. Physicians consistently mistook trauma responses for therapeutic breakthroughs, compliance born of terror for genuine recovery, and the silence of the broken for the peace of the healed. The rotational chair eventually fell from medical favor, but not because physicians suddenly recognized its cruelty. Instead, changing theories about the nature of mental illness gradually undermined the hydraulic model that had justified rotational therapy. The rise of new approaches to psychiatric treatment, including the moral treatment movement's emphasis on environmental factors and the early development of psychoanalytic theory, provided alternative frameworks for understanding madness that didn't require mechanical intervention. The transition away from rotational therapy was gradual and incomplete. Many asylums continued using the chairs well into the late 19th century, long after their theoretical justification had been abandoned. Some institutions simply renamed the devices, calling them therapeutic chairs or calming apparatus, while continuing to employ them as instruments of behavioral control. The physical chairs themselves often remained in asylum basements and storage rooms for decades, silent witnesses to a chapter of medical history that most practitioners preferred to forget. The legacy of rotational therapy extends far beyond the Victorian era. The underlying assumptions that justified its use, that mental illness represents a mechanical malfunction requiring physical intervention, that patient resistance to treatment indicates the need for more aggressive intervention, that temporary compliance represents genuine therapeutic progress, continue to influence psychiatric practice today. Modern mental health treatment still struggles with the tension between patient autonomy and professional authority, between therapeutic intervention and social control. The story of the rotational chair also reveals the persistent human tendency to medicalize social problems and to use scientific authority to justify practices that serve institutional convenience rather than patient welfare. The Victorian physicians who prescribed rotational therapy were responding not just to individual mental illness, but to broader social anxieties about disorder, deviance, and the need to maintain control over populations deemed dangerous or disruptive. The chair became a tool for managing these social fears as much as for treating medical conditions. Perhaps most disturbingly, the rotational therapy system demonstrates how easily ordinary people can become complicit in systematic cruelty when that cruelty is embedded in professional protocols and institutional structures. The attendants who operated the chairs, the nurses who prepared the patients, the administrators who purchased the equipment, none of these individuals saw themselves as torturers, yet all participated in a system that inflicted profound suffering on vulnerable people. The diffusion of responsibility within the asylum system made it remarkably resistant to reform. No single person felt fully accountable for the suffering that resulted from rotational therapy. The physicians could point to their medical training and theoretical knowledge. The attendants could claim they were simply following orders. The administrators could argue they were implementing evidence-based treatment protocols. This fragmentation of moral responsibility allowed the system to persist long after its harmful effects became apparent to anyone willing to see them. The Victorian rotational chair stands as a monument to the dangers of unchecked professional authority and the seductive power of scientific certainty. It reminds us that good intentions are not sufficient to prevent great harm, that institutional legitimacy can mask systematic cruelty, and that the voices of those who suffer are often the first to be silenced when they challenge established practices. As we look back at the physicians who prescribed rotational therapy, we might ask ourselves, what practices that we currently accept as normal and necessary will future generations view with horror? What suffering are we inflicting today in the name of treatment, security, or social order? How can we ensure that our own confidence in our methods doesn't blind us to their human cost? The rotational chair is gone, dismantled and forgotten, but the questions it raises remain urgently relevant. In our psychiatric hospitals, our prisons, our schools, and our homes, we continue to make decisions about how much control is necessary, how much autonomy can be permitted, whose voices deserve to be heard. These decisions shape lives and determine whether vulnerable people experience care or cruelty, healing or harm. The Victorian physicians who built the rotational chair believed they were creating a machine of mercy, a device that would liberate the mentally ill from the chaos of their condition. Instead, they created an instrument of torture that traumatized thousands of vulnerable people, while advancing no genuine understanding of mental illness. Their story serves as a warning about the dangers of certainty, the seduction of control, and the ease with which healing can become harm when we stop listening to those we claim to help. The chair itself may be silent now, but its lesson echoes through history. The most dangerous people are often those who are absolutely certain they know what's best for others. In our own time, as we face new challenges and develop new interventions, we would do well to remember the spinning chair and the suffering it caused in the name of progress. Only by acknowledging this dark chapter in medical history can we hope to avoid repeating its tragic mistakes. History, like the rotational chair itself, has a way of coming full circle. The question is whether we will learn from its revolutions or be condemned to repeat them, spinning endlessly between the poles of good intentions and terrible consequences, forever seeking the cure that remains just out of reach.